Good evening all, this is Leanne Breckenridge talking to you about the child with endocrine dysfunction. Slide 2 are your objectives. I'm not going to go over those, but you guys can read them. Slide 3, we need to talk about the function of the endocrine system, and this should be a very quick review for you all. You know that the endocrine system controls and regulates different hormones in our body. We use those for energy production, we use them for growth, we use them for electrolyte balance, responses to stress, and also sexual reproduction. Just to kind of give you a background about where the word hormone comes from, it comes from the Greek word, which means I excite. Kind of interesting. It might help you remember some of these crazy hormones. So this first one that we're going to talk about is disorders of the pituitary function. Hypopituitarism is essentially a dysfunction in the growth hormone or a deficiency in growth hormone production. The name of that growth hormone is somatotrophin. It is secreted by the pituitary gland. And if you remember right, these growth hormones are essential for growth and development and also cellular metabolism. So it's very important to remember that as well. So just a quick review, in the anterior pituitary secretes the growth hormone, TSH, ACTH, prolactin, LH, and FSH. The posterior pituitary secretes your antidiuretic hormone and oxytocin. So what does this mean for these children who have hypopituitarism? Essentially, their weight to height ratio is quite different. So there's a huge disparity in that. These guys have a short stature. Their growth is delayed. Their plate closures are delayed. They have an increase in insulin sensitivity. They have an underdeveloped jaw, which you can kind of see the two little boys there that are next to one another. The one on the right hand side kind of has an underdeveloped jaw. And also they have a delay in sexual maturity. Very important to remember. So what you want to do is identify it. Sometimes they'll have a headache, and then you're going to support whatever they decide to do. Many times what they'll do is replace that growth hormone, and these children learn how to take this growth hormone at home. In order to diagnose it, they'll draw growth factors, and you have to draw the blood between 6 a.m. and 8 a.m. and I don't know if you know why, but I want you to think about that. Different causes that can cause, that can trouble the pituitary are tumors, trauma, surgery that may have interrupted for some reason the pituitary. It also may be hereditary, deficiencies in TSH or ACTH. Most of the time this is idiopathic. In other words, we're not really sure what causes it. So just a reminder of some of the results of hypopituitarism. You'll have a delay of secondary sex characteristics. The growth hormone deficiency causes a short stature, as we've already talked about. The TSH is deficient, and they will also have hypothyroidism many times. And the ACTH is also lacking, and so therefore they don't have cortisol. So the opposite of the hypopituitarism is hyperpituitarism. And this is also known as giantism or acromegaly. What happens with these guys is there is an excess of growth hormone after your growing is done. So essentially, after your growth plates have closed, then you will grow. And many times these people are up to 8 feet or higher. Um, and um, so what we're going to do is we're going to take a good family history. We're going to get growth hormone levels. We're also going to do x-rays to make sure those growth plates are closed. We're also going to do some additional endocrine tests and try to identify what's causing it. They may have a history of headaches. The other thing is, if you look at the difference between giantism or excessive growth hormone, you're going to see that in giantism, the person will reach 8 feet. If you look at acromegalia, usually their growth is more in a transverse direction, which means that their head and their facial features kind of spread out, or their head looks larger. There's increased facial hair. They have real deep creases in their face. And these guys that have acromegalia also have a tendency to have hyperglycemia or or diabetes mellitus. So you've got to kind of keep that in mind. On the next slide, I've got a picture of what I picture them as. So we have someone with giantism. You see that young male that is taller than his mother, who's also as tall as the 8-foot door frame. And then on the right hand side you see Shrek, who I picture as having acromegalia. So here's another dysfunction of the pituitary gland that happens in children, and this is precocious puberty. Essentially what this is puberty that happens way too early. Manifestations of this early sexual development: for boys, it's before age of 9, and for little Caucasian girls, it's before age 7. If you're an African American girl, it's before age 6. Essentially, what happens is there is a premature activation of the hypothalamic pituitary, or an early release of the gonadotropic hormones from the anterior pituitary. And so essentially what we're going to do is we're going to do an assessment on these kids. We're going to look for breast development. We're going to look for secondary sex characteristics that may be happening, such as increased size of scrotum, pubic hair growth, enlargement of the penis, hair under the armpits, deepened voices, those kind of things. And based on the cause, depends on what is really causing it, but we may do hormone injections. And those are IM injections that we also allow the families to give at home. The most important thing is that we give these families some support and guidance. It's really difficult when you have a 6, 7, 8-year-old little female that has already started her period. It is, no one else in her class is doing this, and she's bleeding, doesn't know what to do with it. She's still just a little child, and it can be very frightening for them. So what can cause this? It can be tumors. There can be a defect in the brain of some type. Radiation, for some reason. If a child has had radiation, it can destroy that area. Any kind of spinal injury, hypothyroidism, adrenal hyperplasia, and ovarian cysts or ovarian tumors can also cause it. In boys, that was in girls. In boys, there's usually a tumor or some kind of gene mutation that causes it. And so just a reminder is that we have a cascade of the gonadotrophin releasing hormone, which is GnRH, that causes production of the FSH and the LH and testosterone or estradiol. A rise in the LH or the FSH will happen 30 minutes after we give the gonadotrophin releasing hormone, and that's how we confirm the diagnosis. And of course, on your next slide, you're going to see a precious little guy with precocious puberty. I don't have that on this particular slide that I downloaded. So the next thing we're going to talk about is diabetes insipidus. This is undersecretion of the antidiuretic hormone, or ADH, from the posterior pituitary, which means that the child has uncontrolled diuresis. In other words, the kidneys cannot conserve water when it's trying to filtrate. Causes for this are numerous: head injuries, infection, loss of blood supply to the hypothalamus, surgeries, a tumor, and or family tendency. Now, I will tell you that up to 50% of them are idiopathic, and we don't know what causes it. Signs and symptoms of this are excessive thirst, they crave ice water of all things, and excessive urine output. And so let me also tell you that it can also, one of the causes can also be nephrogenic, which means that something has caused a hit to the kidneys, and medications like amphotericin can do that. So you have to watch it when you're giving some certain medications. How do we diagnose this? They do a UA, and what they will do is they will look at it and note that the urine is going to be very dilute, so the osmolality is going to be very low. They're going to withhold fluids and watch to see if this child continues to void. And then we can look at ADH in the lab values. So as you can see up on your slide, you're going to diagnose first by restricting fluids and observe for urine loss and concentration, and or whether or not the child's lost weight. How we treat this is we give them vasopressin. We do strict eyes and nose on them, and we treat the cause if there is a cause that we can identify. Naturally, with your nursing assessments, you're going to do a thorough assessment with them. You're going to talk to the family about intake and output, and you're going to do some other teaching at home so that they know what to look for. Some of the first signs of diabetes insipidus is bedwetting, and so it's very important when families come in to talk to them about bedwetting. And some of you may not know, but it is not an uncommon thing to have a bedwetter even past the age of 7. Still, 1% of bedwetters are urinating at night at age 17. And hopefully most of them grow out of it. There are some that do not, but very few. So the older you get, the more likely you are to grow out of it. The important thing about children with enuresis is that we don't embarrass them. You do want to help them take responsibility for their bedwetting, help them make a plan to either set an alarm clock to get up to go to the bathroom, or to help change the sheets, or whatever may happen. You want to meet these children's hydration needs, so because they're voiding so much, they can easily get dehydrated, and so we have to administer IV fluids as needed. So just a review about diabetes insipidus: you're going to have polyuria, you're going to have polydipsia. First sign is usually bedwetting. 50% of them are idiopathic, meaning we don't know what a cause is. How to diagnose it: we're going to restrict their fluid, and we will note that urine will not concentrate as it usually does. So now we're going to talk about the syndrome of inappropriate antidiuretic hormone, or SIADH. This is excessive antidiuretic hormone and hypothalamic dysfunction, where the kidney reabsorbs the fluid and then puts it in the central circulation. So essentially they're not getting rid of it. So of course, if they're not getting rid of it, you're going to have fluid retention and hypotonicity. The urine osmolality will be elevated, completely opposite of what you're going to see in diabetes insipidus. The sodium is going to be low. So why is it going to be low? You've got to ask yourself those things. Signs and symptoms of this: they're anorexic, they become very irritable. There are some personality changes that happen with it. excuse me, they're going to, excuse me, as a nurse in doing care for these guys, you're going to do strict eyes and nose with them. You'll want to do daily weights. You want to watch for signs and symptoms of fluid overload. So once again, there's an oversecretion of the antidiuretic hormone, or ADH. Sometimes infections can cause this, tumors can cause this, head trauma can cause this, just a variety of conditions can cause it. Fluid retention usually happens, and because fluid retention happens, there's hypotonicity. The sodium serum is usually less than 120 milliequivalents per liter. And children can, in addition to the things that are listed with the signs and symptoms, they can also have seizures and stomach cramps with it. So for SIADH, your treatment's going to be fluid restriction, so that they don't retain what they can't get rid of. You're going to check the urine and serum osmolality. You're going to watch their electrolytes. You're going to watch their BUN and creatinine. You may have to put them on diuretics so they can get rid of that excess fluid. You may put them on declamycin, which helps with the hyponatremia, and also sodium supplements. So what we're going to talk about here is different disorders of the thyroid gland. We have hypothyroidism and we have hyperthyroidism. When we're talking about juvenile hypothyroidism, or a deficiency in the thyroid hormone, these can be caused by congenital anomalies. It can be acquired. There is growth cessation or retardation. It's very important to do early recognition through the newborn screen that they get, and then we will put them on Synthroid if we need to. When you have hyperthyroidism or Graves' disease, and you can see that little girl down in the right hand corner with a goiter, these guys get extremely irritable. They become hyperactive. They also have those big eyes that kind of look like their eyes are bulging out. So very important to kind of keep those differences in mind. I will tell you that you're going to probably have hypothyroidism and hyperthyroidism. You probably have diabetes insipidus and SIADH on your state board exam. So make sure that you guys are well aware of both of these. So just a quick review of hypothyroidism. It's one of the most common endocrine problems of a child. Early recognition will prevent a lot of problems within the first 2 years of life. And as I reminded you, we do this in the newborn screen when we do the PKU. And so we can pick that up very, very quickly. We do treat them over 4 to 8 weeks to prevent symptoms of hyperthyroidism that can happen because of hypothyroidism. And so we have to be very, very careful. So what we're going to do is we're going to start them on some Synthroid, and then we're probably going to check levels to make sure that we don't make them hyperthyroid. This too, just a reminder, can be congenital or idiopathic. It can also be caused by a family history. And 1 in 2,500 babies are born with this. The other thing I want you to remember is that when you are treating somebody with Synthroid, that you are not to give them food with the Synthroid, which is really hard when you have a newborn who eats every 2 hours. And the other thing is you don't want to give with calcium or iron, which can be also very, very tricky. So those babies that are formula fed, probably the best thing to do is give it to them about an hour after they eat, which essentially tells you, golly, hardly seems like these children even get a break. Excuse me. Children that are treated early usually have real mild delays, but children that are treated later in life are going to have difficulty developmentally and also cognitively. So as you can see, adolescents later treatment demonstrate problems of memory, attention, and visuospatial processing. The other thing is, if we were to look at a child's thyroid via ultrasound, we might even see some nodules on it, which is very interesting. Remind yourself quickly of the signs and symptoms of hypothyroidism. And so with children, you're going to see a slowed growth by the age of 2. You're going to see dry skin just like you would an adult. You're going to see puffy eyelids, patchy or sparse hair, or you will note that when they're in the bathtub that these children lose like clumps of hair. These children are going to be more constipated. They're going to be sleepy and sluggish, and you might even see some kind of mental decline. So very important. Just today we had a child that came in. Mom was concerned because she sleeps from 5:30 p.m. until 6 a.m. the next morning without waking. And we did a hemoglobin on her and she was fine. So what's the next thing we might think of? You might think of something like mono that would make you fatigued or something like that, but she's not had a sore throat, she's not been sick, she just wants to sleep. And so we are doing a thyroid panel on her as well as some other things, but that kind of makes you think when you have an example of a child that's just sleepy all the time, what may be going on. So you also ask, is she constipated? Is she got real thin hair? Is she losing patches out of her hair, etc.? So Graves' disease, I know that many of you know that Barbara Bush had Graves' disease, but I don't know if she was a young child when she was diagnosed with it. Essentially what this is an enlarged thyroid gland, and they also get the I can't say the word. As you well know, I trip over all kinds of words, but the protruding eyeballs. It occurs anywhere between ages 6 and 15 years. The peak incidence of this is between 12 and 14 years. And it can also be present at birth with moms that have that are thyroid toxic. So it's very important for us to look at newborns. It is also 5 times more likely to occur in girls. We're not sure what really causes it. They do think that there may be some autoimmune response to TSH receptors. There also may be a family association with this. And so the way we treat this is anti-thyroid medications, or sometimes we even have to radiate the thyroid to kind of slow things down. So, quick reminder of hyperthyroidism. I want you to stop and think about it. These people are restless, they're tachycardic, they cannot sit still, they get really hot, they're emotional and grouchy, they act tired, although they're not quite as sluggish as the hypothyroidism. They're tired because they just go, go, go. They have weight loss, and many times they're underweight. Sometimes they'll have a goiter. As I already mentioned, they're going to have heat intolerance. They look like they are essentially going through menopause at age 14. And they also have warm, moist skin. And when you compare that to hypothyroidism, everything is dried out. So you have dry skin and a dry gut, which causes constipation in hypothyroidism. In hyperthyroidism, that is not the case at all. Your bowels are fine, and you may even have some diarrhea, and your skin is moist. So type 1 diabetes, I'm not going to go into this a lot because I think you guys have been tested and tested and tested on diabetes, and I think you guys ought to know it by now. Now I know that I will have a few questions on the test for this or with this, and but I don't think it's something that we need to go into a lot of depth with. Real quickly, diagnosis: these guys are going to have glycosuria, which is essentially excess sugar in their urine. They're going to have polyuria. They're going to have a history of weight loss. That's one of the very first things you're going to see in children, is a history of weight loss or failure to gain weight. They may have a transient or persistent glycosuria, and then even get into some metabolic acidosis with or without stupor or coma, depending on how high their blood sugar is. So the reason why they go into metabolic acidosis is because their kidneys cannot get rid of the acid. So with that, you're going to have a low pH, which is going to be lower than 7.4. Just a reminder of what diabetes is, or type 1 diabetes is. It's the inability to produce insulin, and it may be due to an autoimmune issue where it destroys the beta cells in the pancreas. We don't really know. And of course, you already know that insulin is needed to put glucose into the cells for energy, or to the liver for glycogen storage. Some other things I wanted to point out is it is the most common metabolic disease known. We want a fasting blood sugar of 120, it will be 120 or less if they're normal, 120 or more if we are concerned about them having type 1 diabetes. If you do an oral glucose tolerance test, it's going to be 200 milligrams per deciliter or more in the blood sugar, or with the blood sugar, if they are type 1 diabetics. Some of the things that can cause nausea and vomiting, abdominal pain, dry mouth, they can be tired, they can have a weak pulse, they can also have confusion. The other thing you want to talk about is withdrawing a hemoglobin A1C. It is anywhere from 4 to 6 for normal for people without diabetes. If they do have diabetes, it's anywhere from 6.5 to 8, with our goal being somewhere around 7 or less. One more thing that I wanted to point out about metabolic acidosis is just a reminder that when your cells cannot get energy from glucose, that your body burns fat. When fat is burned, it makes ketones, which is an acid, and that is why your kidneys have a difficult time getting rid of the acid. So what does insulin do? It helps metabolize our carbohydrates, fats, and proteins and transports them into the cells so that we can use them for energy. It also helps with transporting glucose into the muscle and fat cells, that's what I just said, and then also the storage of glucose as glycogen in the liver and the muscle, and that is used for times when we need them for extra marathons or whatever we're doing. So what is our goal with type 1 diabetes in the child? We're going to monitor their blood glucose. We're going to do a hemoglobin A1C probably every 3 months to make sure that they're within adequate range, and we're going to adjust their therapy depending on what it says. And of course, goals of therapy depend on the age of the child. It is usually not appropriate to put an insulin pump on a 3-year-old who cannot yet count carbohydrates. Once they are more independent or the parents can help, then we may allow that to happen. Usually insulin pumps are given to adolescents or older, close to teenage years. And these children are remarkable, and they can count their carbs and adjust their insulin as needed. So treatments for hypoglycemia, you want to give them 15 grams of carbs and glucagon. Remember the Smogy effect, which means that they peak at bedtime and then they have a low blood sugar at 2 a.m. And then remember too the dawn phenomenon, where they peak at 3 a.m. and then the blood sugar is high in the morning. Sometimes it's very difficult to adjust insulin depending on if they have either one of these. So here's a comparison chart between type 1 and type 2 diabetes. Very interesting that type 1, you usually see an onset less than 20 years old. Type 2 diabetes, we are seeing an increase in younger age children. As a matter of fact, I saw a child today that is about probably 8 years old, and he weighed 154. and the child was on ADHD medicine, and the mom was like, he just never eats, and I don't understand why he's as big as he is. Well, he's as big as he is because he's not eating the proper food, and so that is more geared toward the type 2 diabetes. He had the buffalo hump and some other things that made it interesting enough for me to send him to get some labs drawn, and I am thinking that he's going to have type 2 diabetes. So back to type 1, there is an abrupt onset. As a matter of fact, the child is leaving on vacation, they're driving down to Florida, and all of a sudden the child has to pee 15,000 times on the way to Florida. And the parents are going, what in the world? That doesn't happen with type 2 diabetes. These children have a gradual onset and usually have a huge weight gain, and eventually it's going to go downhill for them. Type 1 diabetics are going to be underweight, and type 2 diabetics are going to be overweight. In type 1, the serum insulin is low or absent, and in type 2, you're going to have a really high insulin level or a low islet cell antibody, depending. With type 1, you're going to have ketoacidosis, which is very common, and ketoacidosis in type 2 is very, very infrequent. In type 1, usually you're always, well, not usually, you will always have some type of insulin because you don't have enough insulin to take care of your needs. In type 2, you may or may not have insulin, but more and more we're putting children on, first we're trying dietary measures. If that does not work, then we will put them on metformin. And it is not uncommon for us to have 10-year-olds on metformin already. We will usually start them out on about 500 milligrams, and then we will increase it to 1,000 milligrams. 1,000 milligrams meaning 500 in the morning, 500 at night. One key thing about the metformin is it can cause some GI upset, and so it can be very challenging with these kids. So long-term effects from either one, if we don't take care of ourselves, neuropathy, retinopathy, kidney damage, cardiovascular disease, altered thyroid function. And so because of these, you have to ask yourself, what am I going to teach these families? What is important? Well, the type 1 diabetic is going to be a little bit different than the type 2 diabetic, and I think you guys can figure that out. With type 2, you're going to teach dietary. Type 1, you also have to teach some dietary restrictions as well. And many times they're very much the same. I try to teach my families that anything white is probably not good to go in your body. And what I mean by that is sugar is white, rice is white, potatoes are white, so you can think of all those white foods that are probably not real good for you, that are high in carbs. Remember too that a yearly eye exam is essential. Foot care, even for young kids, is important. It is also very important for them to all exercise. And that when they are sick, they need to monitor their glucose every 3 hours, if not more. And then the last slide I have for you is the types of insulin. There's rapid acting, short acting, intermediate acting, and then long acting. You will need to know the different types of insulin and how quick they react. So a rapid acting insulin is going to act within 15 minutes and it can last for 5 hours. A short acting type of insulin will act within 30 minutes and it can last up to 8 hours. Intermediate will act within 2 to 4 hours and can stay in the blood for up to 20 hours. And then long acting acts within 6 hours and will stay in the bloodstream for up to 24 hours. So it's very important for the endocrinologist and you as the nurse caring for the child with diabetes to monitor their blood glucose so that we can see what's happening. Be prepared for those low sugars in the middle of the night if that happens, or a high sugar in the morning when they arise, depending on what's happening. It may take a while to get their insulin regulated. Please let me know if you have any further questions. Thanks and have a great night.